Greetings. The title of my poster presentation is Post-COVID-19 Organizing Pneumonia with Acute Pulmonary Embolism and Possible Pulmonary Aspergillosis, a case report. A 41-year-old male with underlying insulin-dependent type 2 diabetes mellitus was admitted in June 2021 with cough, fever, and anosmia for more than 1 week. He was admitted to the ICU and treated as COVID-19 category 4. He was discharged well on day 22 of COVID-19 infection. The patient was readmitted 2 weeks after that due to worsening clinical condition and hypoxemia. Respiratory examination revealed bilateral lung crepitations up to the mid-zone. Lab test showed an elevated white blood cell count of 8.68 times 10 power of 9 with 57.5% neutrophils. CRP was elevated at 66.6 milligrams per liter and serum procalcitonin was elevated at more than 52 nanograms per ml. Chest X-ray revealed ground glass opacities and blunted costophrenic angle in the lower zones bilaterally. He was diagnosed as hospital-acquired pneumonia. His condition deteriorated on day 4 of ICU admission, requiring mechanical ventilation. Antibiotic therapy was escalated from piperacillin tazobactam to meropenem. It was started empirically on anidulafangin for COVID-19 associated pulmonary aspergillosis. Urgent CT pulmonary angiography and high-resolution computed tomography revealed evidence of pulmonary artery thrombus and organizing pneumonia. His D-dimer was elevated at 0.88 micrograms per ml. He was given intravenous heparin infusion for pulmonary embolism. The results for blood Aspergillus PCR and serum galactomannan assay both came back as negative. The patient responded well and was intubated. The patient was discharged well after 21 days of hospitalization with oral prednisolone and warfarin. So, for discussion, although this patient's result came back with negative for Aspergillus PCR and serum galactomannan, we can still say that we can still classify the case as possible pulmonary aspergillosis based on the criteria by European Organization EORTC MSG criteria, which states that patients that have host factors and clinical features but in the absence of or negative mycological findings are still classified as possible invasive pulmonary aspergillosis. And also another health problem patient face is pulmonary embolism. So acute inflammation caused by sepsis can alter the coagulation status, and almost 20% of patients with COVID-19 develop hypercoagulable states.